Um, Good morning, afternoon, evening, wherever it is you're listening to this. This is chapter 22. You're going to find this volume 3 of your Merrill's Atlas, actually. Both pediatric and geriatric. These chapters it's not really specific learning imaging as much as it is learning like the behavior of this type of patient and how you techniques and tricks of how to deal with this type of patient, not only this one, but the geriatric patient. So they don't really fit in really well. I know that they have to be like near the beginning because you are going to encounter pediatric patients and geriatric patients, and I do want you prepared for them. So I had to front load it to October, but I mean, it really doesn't. I understand why they put it in volume 3. It doesn't really fit really well anywhere. So anyway, here we go. This is pediatric imaging. I don't really have objectives, but I want you to learn the ins and outs of pediatric imaging. I want you to understand that your pediatric patients are different than your adult patients, that even different age groups within pediatrics are like the way that you treat adolescent patients is different than the way you treat 2-year-olds, is different than the way you treat 5 to 8-year-olds. And so there's a lot of different strategies. You always have to engage your patient, and that's going to take a little bit more effort on your part. But now your patient becomes like multiple audiences, because not only is it the child itself that is the patient, but oftentimes it's the parents too, going along for the ride and watching your every move. And some parents are more experienced, some parents are less experienced, some parents are more judgmental, some parents are less judgmental. And so it really becomes almost like a compromise or a negotiation type situation where it's what you're negotiating for is the cooperation of the parents and the child in the process. And that means that they have to believe you, and they have to understand you, and they have to think that you know what you're talking about. So you have to establish a rapport and a trust with them. And it's a little bit more than it's a little bit more automatic with an adult patient than it is in this particular scenario. Okay. Immobilization, we often immobilize patients that are injured or have acute injury. Immobilization with a child, a lot of times the child doesn't understand and they think it's the injury that's causing the pain, but some children think it's the immobilization that's causing the pain. And immobilizers are scary when you get put into a splint for the first time, and it's your first experience with an arm splint or a leg splint or something like that, or being weighed down by sandbags or lead aprons or a combination of both. It's a little bit frightening. It's kind of not what you were expecting, and so we got to be aware of that we're going to need the child to hold still, and so we're going to need to utilize some immobilization tools, and sometimes that's going to build fear and anxiety in our patients. Okay. Now, in the case of the Pigastat, that's exactly what we want, because we want them screaming their lungs out, so they take a nice deep breath after they scream their lungs out. So. And then finally, active communication. If we can get a verbal connection with the child, and maybe play pretend a little bit, maybe use our imaginations, or maybe just bring it down to their terms and invite them in, especially in the case of an adolescent. Invite them in, explain what you're doing, explain why it's important, and typically any child over the age of 10 is really going to appreciate that you're treating them like one of the adults, especially the teenagers. they like to be treated like they were adults. So you do have to adjust your communication depending upon what age range you are speaking to. So all of these are factors that a radiographer, and they kind of come to the front burner a little bit more with a pediatric population than they do with just your run-of-the-mill adult patient. Okay? So it all starts with the waiting room, and I laugh at the little, whether that's a fish tank or just a bubble fountain or whatever, look at all three sets of eyeballs. Every child, even the kid that is too big for that plastic four-wheeler thing. Yeah, if your elbows are touching the handlebars, kid, it's not meant for you. It's meant for the smaller folks. But every one of them enthralled by the fluorescent green, that's like radioactive waste green, and the bubbles. And of course, that's LED lights and just a bubbler. I don't think it's a fish tank, but a fish tank is just as effective with children. We want it starts the waiting room and basically the exam room environment. Everything needs to be inviting and warm and needs to be centered around the kids. Children's Hospital of Vanderbilt and Centennial Children's Hospital, they do a great job with the aesthetics and the environment and making it it feels like a play space. It feels like almost like a kindergarten or like a recreation room rather than a waiting room for patients. And that's important. We want the child to feel comfortable in the environment, because if they're comfortable in the environment, they're more cooperative. Okay. So, and again, I touched on this before, but all these things kind of come to the front burner, and especially the communication. Communication is central to, if your communication is subpar, you're going to struggle to complete your pediatric x-ray exam, okay? And so you got to do your due diligence. You have to, you got to talk about it. You got to bring it down to their terms. You got to involve the parents, include the parents. You have to explain, take a little bit more time with the explanation, okay? Tell them why it's important, and of course, and that's for the older pediatric patients. The younger pediatric patients, your communication is going to certainly acknowledge the patient, but most part, the instructions are communicated like with a toddler. You're kind of communicating with the toddler, but most of the instructions are back to the parent, okay? Because we know that as the child gets younger and younger, right, the more we're going to need the parent's help to get the exam performed, to hold the child into the correct position, and offer reinforcement and guidance. And so the parent becomes like a collaborator in the performance of the exam, but they can't do that if they don't know what you expect from them, okay? Also remember, in all of this where it's kind of difficult to get things rolling, and you gotta change up what you usually say and adjust it to your audience and stuff. Remember that they're here for a reason, and there's some suffering going on, and there might be, and really, you remember how I might have said before in the customer service lesson, the X-ray tech sets the mood. Well, you're going to be wrestling for the mood with the parent. The parent sets the mood. The child reads the mood from the parent and then exacerbates that because the child lacks maturity. It's totally feeding off the emotions of the parent. So if the parent is a new parent, they're kind of rattled and frazzled and anxious, the child's going to be anxious and nervous too, okay? And that's because we don't often see that. We don't often pay attention to that. But as parents, we're constantly setting the mood for and adjusting the mood as necessary in order to elicit a certain and manipulate a certain response out of our children. And so we need to be respectful of that. That is the parent's job. That's how the parent performs the parenting job, is setting the mood, setting the tone, and setting expectations for the child. We need to buy into that and co-opt that and say, okay, well, this is the specific task that we need to do, and make sure that our parent has really bought in. And if the parent is just worried out of their mind because this might be their first kid, this might be the first time the kid was like seriously sick that they had to come to the hospital. And so understand that just getting a hold of the mood, that might be the first part of the uphill climb. Okay. Another thing about pediatric safety, there are evil people in the world that like to abduct kids, and so we're responsible. Typically the parent's responsible for that. Not to say that it's the parent's fault that the kid gets abducted, if that, God forbid, that ever happens. But we're an extra adult that's equally responsible for this frame of time that the exam is taking place. And it might be that, like me, parent of a special needs child, I've taken my kid to the hospital at least 200 times, right? If I see that someone's coming in and it's going to take about 5 minutes, yeah, well, I need to step out and go to the bathroom, or I need to step out and make a phone call, or I need to run up to the cafeteria and get a sandwich because I'm anticipating that we're staying overnight, and I need to, make preparations for me getting a dinner. And so you got to be aware of that sometimes with the experienced parents, if they, like me, if I read you and I believe in you and I think that you know what you're doing as a nurse or an x-ray tech or, a patient care tech or whatever, and I trust you, I'm totally like dropping my part of the responsibility and say, hey, I know you got to do something, but yeah, just watch them for about 5 minutes. I'll be back. Thanks. So you got to watch out for that and never leave your patient unattended. And that's, for me as a parent of a special needs child, that's, going to the hospital is a pain. It's a necessary pain, but also I'm also taking advantage of, yes, there is an opportunity for me to drop my responsibilities, and it's a great relief that I can just hand that off to another competent adult for 5 minutes, and I don't have to be the one that's on guard and watching and making sure that Aiden is doing what he's supposed to be doing to get healthy, and that he's comfortable, and all his needs are being met, and his pain is being managed, and all that kind of stuff. I want to break from that too. And your parents, not your parents, but your patient's parents, they might want to break too. Okay, so you got to be on guard for that, and you got to understand that sometimes it's like, oh well, yeah, I guess I am babysitting for a little bit. It's not the end of the world. Okay, enjoy it. You basically get to take a break and go back to 3rd grade and play. It's fantastic. Okay. The other thing on this slide regarding safety is, yes, kids and jail prisoners like to swallow things that they shouldn't. So just watch out for any loose items. Your letter markers are a little bit big, but yeah, if you got an aggressive child that's just extra curious, the 18-month-old, he or she will just, that's the first thing, they get it into their hands, and it's like, I wonder if I could eat this, and then bang, it goes into their mouth, right? And then depending upon what it tastes like determines whether they spit that out or not. It's just so comical to see how fast it's like, oh, it's in their hands, and bang. Oh yeah, can I put this in my mouth? Is that appropriate? Will it taste good if I put it in my mouth? Yeah. And so it's just they're just little science. They're not formulating a hypothesis, but they're definitely conducting experiments. They're cute in that way. You can, if you watch the toddlers, they're the best because they're 100% learning, explore. What does this do? What does that do? Can I shove this in my mouth? All right. What happens if I pull the cat's tail? All those kind of things. They're great. All right. So, pediatric radiography communications. All right. Make eye contact. Now, but also when you're looking at the child, right, and you're making eye contact, don't be running your eyes downhill at them, right? That's intimidating. Take a knee, get down to their level, have a face-to-face conversation with them, okay? As soon as you get down to their level and they make eye contact with you the first time, give them a big old grin like you're excited that they acknowledged your presence, okay? And that further reinforces that you're not a threat, you're a friend, okay? So big old grin, big old, your eyeballs get real big. Yeah, that just draws as soon as they make eye contact with you. And then it's like, oh, there's another person right here, and they're paying attention to me. And then they just gravitate, and they're like magnetically drawn in. Okay, don't discount the value of that. Okay, when you're talking to the parents, okay, your eyes kind of bop back and forth between the parent and the child, and just pick up cues for that. And if the parent has a question, yeah, eyes off the child, back to the parent. It conveys that you're listening and taking into consideration what the parent's saying. Yeah. Use age-appropriate language for the child. The child's not going to understand um, inspiration and hold, or many of the adults aren't going to understand that either. The child's not going to understand why this big scary machine is being aimed at them. Okay. Remember how I said it's a radiation cannon? Yeah, most adults don't think of it like that. But children seeing an X-ray machine for the first time, they don't know what to think. It does look like a weapon to them. It's just weird. It's got big wires coming out of it, and then there's a target light on it. Yeah, that's a gun of some kind. Why are they pointing that at me? That's kind of scary. So be aware of that, okay? You want to use the word pictures. We're taking pictures, right? Most kids have birthday parties, and the aunts and uncles come over, and their friends come over, and such. And what happens? People take pictures. So yeah, it's kind of like a party. We're going to take pictures, okay? But you got to get dressed up into your party clothes. Well, that's the gown I need you to change into, okay? And the adult gown is going to look like it's going to be like a long flowing princess dress. So with a female pediatric patient, you can say, well, this is like your ballroom gown, and we need you to put on your ballroom gown, and then we're going to take pictures of you at the ball like you were Cinderella, and then bang, they're thrilled. They're like, oh yeah, it's my princess pictures. This is great. Good luck with the boys. The boys are just gonna, yeah, they're not gonna buy into anything. So anyway. Take history. Now, is the child going to know its history? No, but can you ask an open-ended question about pain or what's going on? Kids love to, like, what's going on? Are you sick? What are you feeling? Right? And are you sick is leading, but yeah, there's a little bit of wiggle room on that when it's a kid, and I mean, you can't. It's really hard to keep it open-ended, but also work it down to their level. So I'll forgive you if you ask the kid, "Are you sick? How are you feeling? What's been going on with you? Um, is there something that hurts?" Even a child can answer that question, okay? Now, if mom or dad steps in and starts explaining, well, then just pivot to them and finish the history with them, okay? But if the child, right, and younger children, mom or dad's going to fill in the history. Older children, they might say, yeah, my throat is scratchy, right? And then you say, well, now, do kids understand chronology? Do they even know what a day is? You could say, has that been going on for a while? But don't understand, most kids don't have a really good handle on what's a day versus what's a week versus what's an hour, at least under 5 years old. So just be careful with that. They might not know. If you're asking them how long they've been suffering, they might not know. So just mindful of that. Okay. Yeah, but then also switch gears if the parent starts rattling off the history, switch gears and then just go into a history conversation with the adult. Okay. Avoid medical jargon. That's just good advice for anybody. But especially, yeah, strange looking machine. They're shining a targeting light at me, and then they're using all these words that I don't understand. And then they're telling my parent that my parent has to stand back from me. Yeah, everything about this is creepy. I feel like I should just scream. And then they do. Or I should just throw a tantrum right now. That's what I should do. Okay. Be mindful not to engage in conversations that are inappropriate in the presence of the patient. So if it is like really bad news and the parents get an idea it's bad news, want to separate and create some space because, maybe it's, we don't want to paint that kind of a picture. It's a terrible thing to do to a child. It's bad enough that they're suffering from something. I'm thinking like a leukemia or a lymphoma, like Hodgkin's or non-Hodgkin's lymphoma, or some kind of pediatric ailment that is also life-threatening. We want to be delicate about that because especially if the child is over somewhere between 5 and 10 years of age, because they will be listening and then they'll start asking a bunch of questions and then maybe the parent's not ready to have that conversation yet. That's an huge emotional lift for the parent. And it's just, it's awkward if the parent hasn't like psyched themselves up and prepared what it is they're going to say and how they're going to present it. And it can just, you can lose control of the mood of the room like really, really fast. So be mindful of that if it's sensitive subject matter and things of that nature. Okay. Ask about questions or concerns before the exam even begins. So we want to get a chest x-ray done, but before we begin, do you have any questions for me? Okay. And is this directed toward the parent? Is it directed toward the patient? Again, it depends on how old the patient is and whether or not they're even engaged in that conversation. The under 5 crowd, they just know that they feel yucky, and mom or dad has brought them to a kind of scary place where they give shots. And so it just went from bad. Not only do I feel awful, but I might get a shot, and this is just a bad day. So use the family teaching sheets when they're available. They do have some hospitals. There are some scripted scenarios that have been formulated, and some software companies do have, like with the in-servicing software and the remedial education, continuing remedial education required for healthcare professionals that the employers provide. Sometimes there's like a scenario lesson where it's like, okay, this is the situation. You have a pediatric child and then this is happening. And the whole lesson is like, this is what you do in this case, this is what you do in this case. And it just gives you contingencies, it gives you options, and it basically just, this is how you handle this, which is great because you can just lean into that, especially if you're a novice practitioner. You don't have, as you gain experience, you'll have been in the same situation before, and you'll remember what works and what doesn't work. And you'll be able to negotiate the conversation, right, and achieve the objectives of establishing the mood and making the person comfortable, and then getting to the exam performance. And then the exam performance is not anxiety driven and it's not fear driven. It's an easy task that's performed in cooperation with the participants, the family, the parents, the guardians, and the child. So respect and dignity. The parents and the patient and the parents are going to have concerns. They're going to have questions. We should be, so when we prompt, do you have any questions? We should give them a little time. We should expect that they do have questions. Okay. And then I put on a show, I think it was just yesterday. You might not be listening to this until next week. I had to do a KUB on a Spanish-speaking person, and it was extremely difficult. I had forgotten how difficult it was, and there was miscommunication the whole way. I stumbled through, and I remembered some of my Spanish, but I stumbled through, and I did flub the discharge of the patient and the release of the patient, letting them go. I thought I clearly conveyed that the patient could get dressed and go, but they were there like 5 minutes later still waiting, so I had to go back out and reassure them that we were done. So that was a miscommunication on my part. And when your patient doesn't speak English and the family doesn't speak English well, yeah, you can, the ball can be dropped, so to speak, and you can have a miscommunication, and it could, now in that case it was more of a customer service flaw, didn't dismiss them on time, but there wasn't really any safety issue, so to speak. But a miscommunication can lead to a safety issue, so just be mindful of that. Okay. Cultural preferences too. I think I mentioned when you're talking to Egyptian men, they're going to, something about Egyptian culture, they stand way too close for Americans. They stand like maybe 8 inches from your face. Okay, you can smell what they had for breakfast. Okay, it's kind of awkward, and they're in your personal space, and sometimes they don't understand. That's actually how they conduct business, is at an 8-inch face-to-face distance. Okay, so to them, that's professional conversation. Okay, but to you, they're inside your personal space, and you want to back out to about 1.5 feet away. When you do that, they're going to step towards you. Okay, so you just have to understand certain cultures don't communicate the exact same way. Okay, I think I also mentioned that outside of the United States, there are several cultures that the thumbs up is the equivalent of the middle finger. And so you want to watch out with your hand symbols for approval. Okay. Respect their privacy. Knock before entering their exam room. Okay. If you don't have separate dressing booths and you're having them change into a gown in the exam room, yeah, been there, done that. Always knock first to make sure that they're ready for you. Okay. Adequate quick care and service, child-friendly environment, appropriately sized equipment. Parents will know their child best. Utilize your child life specialist. You are going to have, it's kind of like a patient care rep, but it's specifically for children. That's the child life specialist. And so a lot of times the child life specialist can be like a customer service liaison to help you with the performance of the exam. Now, I wouldn't have the child life specialist hold the patient, okay, not unless it was absolutely necessary. But they can be a go-between between you and the parents and you and the child. And they can be, just an extra corroborating adult that lends to the legitimacy of your expertise, and you know what you're doing, what you're saying is truthful, and the game plan that you are asking them to participate in is a good game plan, and they need to help you out. Okay. If we can, we do want to use a foam mattress, 1 inch. If you go farther than 1 inch, then it is going to start affecting attenuation ever so slightly. But a 1 inch pad is fairly radiolucent, but it can provide extra comfort instead of just the hard exam table. Okay. Place the patient on the exam table when ready to proceed. Make sure we're doing this with safety. If you have an ambitious 4-year-old or 5-year-old or such, they will just climb anything, right? And so if you say climb on up there, they will start climbing on up there. Arms and legs on all fours, and they will just get up, whether it's a safe maneuver or not. They might even take a running jump up onto the table. So, yeah, kids' risk assessment is suspect. Right, your preemie infants, the specific risk with premature infants is hypothermia. Typically, when we do premature infants, we take a portable machine up to the NICU. And then there's going to be reverse isolation precautions too. So we're going to be wearing gloves and gowns and masks, and we're going to be wiping down our equipment before we even enter the neonatal ICU. Okay, so prematures and neonates, we got to watch out for infection control and immune system precautions. Infants and toddlers, we're going to encounter them in the emergency room, sometimes as inpatients, sometimes as outpatients, okay? And partly cooperative. Near the end of the 3 years, they start figuring out and making sense of even though it's wildly imaginative, it's still the right way to reach them. At 3 years of age, they can start to play pretend, and that's how you get them to take the x-rays. But the 18-month-old, no, don't expect much thought process and imagination. It's more going to be managing the emotions and keeping the child calm is going to be the secret to the 18-month. Okay, your preschooler and your school age, super curious, asking a whole bunch of questions, so be prepared to answer their questions. Show them how the equipment works, especially those 6 to 12-year-olds. That's an opportunity to enthrall a future x-ray tech, because that's when they're starting to think about, oh, this is what adults get to do when they grow up. And so when I grow up, I might be able to, I wonder if this is a neat or a cool job. It absolutely is. Watch this. And then just move the x-ray machine around, or bring them back. Yeah, if they're over 6 years of age, now you can't tell them what the images are, but bring them back into the control area and say, that's you from the inside. Okay. Don't show them the exposure switch. They'll be tempted to press it, but you can say, this is how we set up the machine. This control panel here is how we set up the machine to take the x-ray. And then when we take the x-ray, it shows up on this monitor, and we can actually see your insides. This is your heart. Those are your lungs there. This is your ribs here, right? And then mom's going to say, well, do you see anything wrong with that? And then you can give the whole spiel about, well, we don't actually read the x-rays, but I am trained well enough to identify the anatomy on the x-rays, and so that's what I'm able to show. But I can't really tell what the diagnosis is. That's up to the radiologist. So, but yeah, all the way now, your 12 to 18-year-olds, they're probably going to be too cool for all of that. But your 6 to 12 years olds are going to be, those are like the best patients because they're just wildly curious about everything you're doing. And they've got so many good questions. So be prepared for that they're going to ask you questions. And you should know the answers to those questions. Okay. So our premature infant, yes, I did say hypothermia is a risk. So if they're coming down, which is rare, typically your premature infant is kept in the NICU so they can keep them in an incubative bassinet, an incubator bassinet with heat lamps and things. Okay, and that's because the premature infant wasn't born with the baby fat. The adipose tissue actually is the last stage of pregnancy, and that starts depositing after all the specialized organs are formed and the specialized tissues are formed and you got a heartbeat and basically you're a baby, you're fully specialized. That's in the last like month and a half, that's when the baby starts packing on just extra calories as adipose tissue to insulate them because they're about to leave the womb and they're going to need to regulate their own body temperature. Well, if the infant's born premature, they have all the specialized organs and they're a baby, they just don't have any baby fat. And so they don't have any way, they don't have a really good mechanism to regulate their own body temperature, and they're always at risk for hypothermia. So that's why we keep them in a warmer bassinet with an artificial heat source. So if they are coming down, we're going to need to accommodate for that condition. Okay, the premature infant, you should have a radiolucent cushion. It might be as simple as a baby blanket between the imaging plate and the child, but it could be a foam pad. It could be a 1-inch foam pad. If you don't have a foam pad, a baby blanket or a couple layers of baby blanket, so long as there's no wrinkles or creases in those, that'll be sufficient cushion that you can lay them on. I wouldn't, probably if I'm doing premature, I'm not going to use a grid, so I'm probably going to do all the exposures tabletop. Okay. Create a patient immobilization plan that will accommodate the patient's condition. Okay. Typically, that's a burrito wrap or a swaddling wrap. Okay. And I think they have stepwise instructions on how to do that in the book, or at least they used to in previous editions. Understand some patients can't be swaddled. I'm thinking in particular child abuse victims. They might have multiple fractures and bruises, and a swaddling might shift the position of a healing fracture. And so it does wrap the baby pretty tight, okay? Like a baby burrito. So just check with nurse if there's any kind of precautions, okay? The warming lights will have to be swung out of the way so you can take an overhead x-ray. Make sure you're replacing those as fast as you can, okay? Most of your preemies are also immunocompromised, so due diligence with your, treat it like it's droplet precautions. So mask up, surgical mask, gloves, and gown, right? You're not protecting yourself against any kind of illness the patient would have. You're protecting the patient against any kind of illness you would have. So it's a reverse isolation type situation, and that would be a droplet type precaution: gloves, gown, mask. Okay. Your neonate, actually, you know what, babies actually feel more calm if you wrap them tightly. like a baby burrito. Okay, so long as they don't have a fractured arm. Okay, so swaddle them up, bundle their arms up. Try to do it. There's a specific method in the book where you actually use folds and loops in the blanket to hold their arms at their sides rather than conventional swaddling. Okay, you want to be quiet. So if you're working in a team, um, keep your voice at a whisper. Maintain a warm room. If you're in a portable environment, replace the heat lamps as fast as you can, like in between exposures. Um, Speak soothingly. A lot of shh, that's it, shh, it's okay, that kind of thing. Just the shh noise is going to settle them in, okay? And avoid sudden, quick movements. You want to be gentle and deliberate with your motions. Yeah. Okay. If you're lucky enough to have a parent with you as you're performing this, um, communicate to those caregivers. Now, it might not be a parent, it might be the patient care tech. Communicate with them, ask them to perform certain tasks. Don't make it too complex in your explanation. I just need you to raise the patient up with the blankets underneath, and then I'm going to slide this board under, right? Typically, if it's a patient care tech, they've probably done the x-ray before, another x-ray before with somebody else. And so they'll be able to follow your lead if you give them instructions, okay? Be kind to if your patient care tech is holding the arms for a chest x-ray or an admin or any position, if they're holding the arms and the legs and holding the child still, provide them with a full body apron. They don't want to be there right up next to the x-ray beam catching a huge dose of scatter, and it's not going to be a huge dose because the patient's body part is not that big. But common courtesy, if they've got to stand there and hold, give them a lead apron. Okay, ask them if they want the thyroid collar, okay? And then help them out with that, right? Use of pacifiers, sometimes with a cleft palate, pacifiers are not recommended because they actually can exacerbate the cleft palate. So you want to ask about that. Humming a song, right? Just nothing with vulgar lyrics, okay? We can do without those. Just the tune, just do 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 do, la 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 la, boom 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 boom. That kind of stuff. Just a little sing-songy. Gives the patient something to pay attention to, and it's just kind of background noise is soothing to a baby. So if you have a vacuum cleaner, run the vacuum cleaner. They'll fall asleep in like 2 minutes. As soon as you turn the vacuum cleaner off, they'll wake up. But yeah, okay. So, oh, isn't it cute? Look at that. So an infant, yes, these are the cute ones. Not that the preemies and the neonates weren't cute, but now they're pudgy. Now they've got that baby fat. They've got that adipose tissue, and they're starting to mimic your facial expression. So if you smile at them, they'll smile at you, and that's the first form of communication. And so they're they're starting to figure out that there's other entities besides them, and there's other things to pay attention to than I'm cold or I'm hungry or my diaper is wet. So now this is the point when they're an infant. This is the point. Typically, it's attachment to the mom. But if dad's a single parent or dad does most of the caretaking, it could be a separation anxiety with either parent. Okay, and it usually involves when the tech takes them away out of mom's arms to be positioned on the table, they just start screaming bloody murder and reaching for their mom, and that's because they think you're taking mom away from them. And the reason they think that is because you are. Mom has to get out of the unless mom's holding, mom's got to get out of the room or else she's going to catch a dose. So most of the time, mom is holding though. So give her a full body apron. Of course, we're going to use a radiolucent table pad, um, especially these are the creatures with the big heads. And so the head will go conk before you know it because their neck muscles are not strong enough. This is a temporary posture. This child is about to drop their head right into that. So soft surfaces because at any time the neck muscle will get fatigued and that overside head will come crashing down. And that's the worst sound in the world is the donk when the infant bangs their head against the hard exam table. Okay? It just makes you kind of, oh God, I hope the parent didn't hear that. Okay? But just understand that they don't have good torso and trunk control and neck control yet. They don't have a lot of strength in their neck. They can they're just starting to figure out moving their head around and looking around and making eye contact and facial expressions, but they can't hold their head up for long. They will eventually donk. So just watch out. Okay. All right. Your toddler is got a short attention span, but they are trying to, and they're excessively fearful and have anxiety. And the toddlers are the ones that read anxiety or they read emotions from the parent. If the parent's chill, then the kid's going to be chill. Okay? If the parent is a nervous wreck, the kid's going to be a nervous wreck. Okay? Not all the time. It's not always a straight mirror. Sometimes there's just anxiety prone children or toddlers. Okay? Especially if you overload their plate. Okay? So focus on one thing at a time and don't dump a whole lot of information at them. You know, like I do to you guys. Don't do that to your toddler when you're trying to take an X-ray exam on a toddler. Just one instruction at a time, one explanation at a time. If they ask you a question, stop and answer the question, right? And just, really consider it and really kind of sell that you're buying into the conversation. And then they know that you're paying attention to them, and then they'll pay attention to you because they know that you're paying attention to them. Okay? Um, do they have a security parent? Do they have a security blanket? Do they have a security toy? Do they have a favorite toy that they brought with them for comfort? Okay? If they don't have something like that that's distractible, then we need to create, through our imagination, we need to create distraction. And so we need to talk about make believe and the child's imagination and say, what do you like to do when you're not sick, when you're feeling better? What's the first thing you're going to do when you feel better? Oh, I'm going to go ride my tricycle, or I'm going to play video games or some such, and boom, you got them, and then oh, I love riding bicycle or tricycle. Well, I ride a bicycle now because I'm bigger than you, but I remember riding a tricycle when I was little. It was great fun. My parents only let me ride up and down my driveway. They wouldn't let me go out on the road. Do you have sidewalks to ride on, or where do you ride? Do you ride do they take you to the park? Where is it you ride? And then, bang, you got a conversation rolling. And meanwhile, you're like reinforcive touch and like steering the kid. But you're just having this little social conversation with them, and they don't even notice that you're putting them in position. It's fantastic. Okay? Oh, good job. That's great. I like that. Yeah. Okay? Positive reinforcement. Some say it even works on X-ray students. No one's yet to conduct that experiment. So someone out there needs to be the first person to actually praise the X-ray students, and then we'll see if they respond well to praise. So we've been educating people how to do this for 120 years, and no one's thought to praise the students yet. So I don't know. That's just weird, isn't it? Okay. Um, Potential obstacles. Fear. That's a potential obstacle for literally any of your patients' fear. And then the separation anxiety. Oh yeah. I've seen toddlers do like the death grip, legs and like they're trying to climb a rope, but it's not a rope, it's mom's leg. And you can't get them to let go, right? It's like, well, you can just, if you just walk over here with that attached to your leg, we can actually just, we can get the side view, and then we'll figure out how to get them unattached from your leg. No, don't do that. That's too much dose for mom. Don't do that. And there's going to be artifact of mom's leg on the image, so don't do that. Get them separated from the leg. Okay. Try to calm the kid down, but get them separated. Okay. Establish rapport. Make it into a game. Provide time for the child to familiarize with the environment. If they're a little explorer and they like run into your room and just start mashing buttons and stuff, well, first of all, keep them away from the exposure switch. But I mean, don't stop them. No, don't touch that. No, let them explore and then say, oh yeah, you know what that button does? It does this. And then show them how the thing works, right? Again, that's getting buy-in. You pay attention to what they're paying attention to or what they like, and then they start treating you like you're exploring the environment with them. You say, hey, you know what's really cool? This machine actually takes pictures of your insides. Isn't that cool? Like you've got a heart and you've got lungs and stuff, and we can actually see those. If you just stand over here, I can set this thing up and we can take a picture. And we'll be able to see your heart. That'll be awesome. It is kind of awesome. Okay. So affirmation, confirmation, praise, enthusiasm in the voice. Get down on their level, make it into a fun activity. As long as it's not the exposure switch, let them touch any button they want, so long as they're not going to get hurt. Okay? But they're not going to break the equipment touching the buttons. You can show them how the table raises and lowers with a little foot pedal. You can let them do it, right? Say, hey, it's got a little motor in there, like an elevator, but it's an elevator for a table. Isn't that cool? Yeah, that kind of stuff. Okay. Your 1 to 3-year-old, this is the in-between zone. Are they going to act? Are they going to act like a newborn and just be a ball of emotions? You get the raw emotion, or are they going to be just naturally curious and not have any fears at all? And just even the 3-year-olds start asking. The 4 and 5-year-olds definitely, and the 6 through 10-year-olds definitely. Sometimes the 3-year-olds, if they've got their stuff together and they're a little advanced, yeah, some of us like, what is this, right? Or what is that, right? And there's no harm. I mean, that's a shield. We use that to stop the X-rays. Okay. Why do we need to stop the X-rays? Well, because you only need X-rays in a certain area. You don't need X-rays over your whole body, and so we put this shield here to keep the X-rays from getting to the rest of you. Okay, they don't need to know. They don't need to know that the X-rays can do damage, right? You don't need to say that to a child. Okay, you just need to say that the shield stops the X-rays, and that we only need to take a picture of a certain part of them. We don't need X-rays to hit all of them. We only need to take pictures of certain parts, and so it's okay to cover up the other parts. And that's all you really got to say. Okay? Are they going to say why? It's like, well, because everybody expects us to. That's a good why. Okay. Avoid, again, unfamiliar medical jargon. Don't confuse so if they are taking instructions, make sure that the instructions are simple enough that you're not confusing them, okay? Because if they get confused, they'll go from curious to anxious and fearful very, very quickly, okay? Avoid words like shoot, shot, or die, okay? Because those are bad. A 6 to 10-year-old, they're going to know that shooting or getting shot, yeah, that hurts. That's bad. That's guns. That's no good. Okay. Give them realistic choices when the choice doesn't matter. That's a great way. Would you like to? I think I'd like you to stand over here in front of this board. Do you want to face toward the board or face away from the board? It really doesn't matter. Your child is not, the child patient is not going to have congestive heart failure. You can shoot an AP chest just as well as you can shoot a PA chest. You don't need a PA chest. The whole heart magnification thing, that's for people who are at risk for heart disease, congestive heart failure, COPD, those type of patients. Your child that you're x-raying has not been a smoker for 30 years. We're not really worried about a magnified heart, so you can have them face the board or have them face out toward the camera. It really doesn't matter. Okay, just note it to the radiologist if you do an AP, just for consistency. Okay, coping and distraction techniques. Blowing bubbles if your facility allows those. Music. So there could be a facility provided iPad in the room or an iPod with selected children's titles, right? You can have them listen to your music on your private phone, but again, just make sure that it's appropriate for the age range. Okay. Watching a movie, that's a little bit more involved, but sure, if that resource is available. Playing with a tablet on the computer is probably not going to be available because we need them to hold still for the exam. And so anything that involves them taking an action, like you can blow bubbles in the room, but you shouldn't hand that over to the child so the child's blowing bubbles, because then you won't get them to stop blowing bubbles to take the x-ray. Okay. Now, another good distraction, and oh, this might play. Well, I'll just send you the link because sometimes when we do the recorded lecture, it doesn't, but I will sing it for you. Okay. And so sometimes a simple song like a popular children's cartoon. This is Adventure Time. It was popular when my son was growing up about 15 years ago. And I absolutely love Adventure Time. Finn and Jake are hilarious. Okay? And so Jake is making bacon pancakes and he sings a little song and it goes like this. Bacon pancakes, making bacon pancakes. Take some bacon and I put it in a pancake. Bacon pancakes, that's what it's gonna make. Bacon pancakes. You got all that? So that simple song, if you know a simple song from a kid's cartoon show, then you can, oh, what cartoons do you watch? And then they tell you, and then you just happen to have the theme song memorized for that, and then you just start singing that song to them. And oh my God, you're best friends with that kid. You're one of the cool ones because you know the song to my favorite cartoon. I will do whatever you say because this is so much fun. I have found another Adventure Time fan or whatever. I forget what one did he move on to. Someone Saves the Universe. I forget who it was. So there was. Yeah, he moved on from Adventure Time. I was disappointed that he did, but anyway. Yeah, that's Bacon Pancakes. I'll send you the song. It is an earworm, so be careful if you sing it and you're acceptable to earworms, you'll be singing it all day. I'll send you the link. There's also a 10-hour version on YouTube. I'll send you that too.
Baking pancakes, making bacon pancakes. Take some bacon and I'll put it in a pancake. Bacon pancakes, that's what it's gonna make. Bacon pancakes.
One more time. How was that? How was my singing voice? Awful? Yeah, there's a reason I'm an X-ray tech and not a nightclub act. All right. But I do like the karaoke after graduation. Adolescents are, well, in a word, annoying. They're not kids and they're not adults. And they don't know what they are. And that's kind of awkward. And so they're kind of awkward. But what they do know is that they are important. And that what they say matters. And that you need to treat them with respect like they were an adult, even though they don't know whether they're an adult or not. Okay? So, privacy. Privacy is front burner for adolescents. Okay? Especially when body changes are happening. Okay? Limit the number of personnel with your teenage patient. Okay? It should be just, and maybe even parent being present might be uncomfortable for them, depending upon where they are on that privacy journey. So, just kind of feel that out. Respect gender preferences of the caregivers if possible. So we do have populations of people that they think that the assigned gender at birth does not match their personality expression. And there's nothing wrong with it. They're trying to find themselves. In fact, that's what life's journey is trying to figure out who you are. That's part of it. Okay? Trying to figure out who you are. Okay? So each and every one of us turning into an adult goes through this process. Maybe not in the same exact way as the people who identify as a different gender through the adolescent years, or maybe even earlier. But people who have different gender preferences, they're going through the same thing you did. They're trying to figure out who they are, and we need to respect their choices. Okay? You may not agree with it. You may think that that's morally wrong. You may think that that is not an acceptable lifestyle for you. Well, that's okay. Keep all that to yourself. It's their choice. Okay? And so we need to be respectful of it because it's their life. Okay? I don't want someone telling me how to live. And it's so therefore, yeah, I understand. Okay? Be sensitive to embarrassing questions. There are going to be embarrassing questions. If we're getting an x-ray, pregnancy is the most awkward issue. Your adolescence, when do you start asking for chance of pregnancy? Typically we're saying 12 now is the industry standard. So 12 years of age and older. We have to ask if the child is sexually active, if there's any chance they could be pregnant. Okay. Your emergency room patients, protocol is also the case that we're typically doing pregnancy screenings before any x-rays are ordered for our emergency room patients. Your outpatients is where it's going to be, because they're going to be coming from a doctor's office. It's going to be like if the girl is 12 or 13, the social assumption is that person is not sexually active, even though we know there are some 12 and 13-year-olds that are sexually active, okay? And that's where it gets, because they're coming from the doctor's office, so really deferring that conversation to the doctor is not an alternative. Now you can still defer the conversation to the radiologist if you think it's going to be heading into awkward territory. But you have to clarify pregnancy status before you begin on every female patient of reproductive age from age of 12 up, okay? All right, so validate and reassure their emotional response. So we have to put empathy on the front burner with, especially if the privacy is on the front burner, we've got to put empathy on the front burner to match and to recognize that they want to be treated like an adult, but this is all brand new to them. And so they're a little unsure of how they're supposed to act, and it's all just a little awkward, and we need to recognize that, okay? So calming techniques, deep breathing. If you sense that your adolescent patient is nervous, go right into the little Zen. Hey, take a deep breath. It's okay. You know, just here, I'll do it with you. Let's go. Let's take in a deep breath, and then let's blow that out. Okay, and as you blow that out, just feel your entire body relax. Let's do that a couple times. Okay. Can you play some of their favorite music? Can you talk about the sparkly, what? The sparkly vampires are over? You don't even know about the sparkly vampires? What? Well, that's just, well, you guys can read my comments. I'm not going to go into that, but go ahead. Okay. Patients with special needs. This one is near and dear to my heart because I am the parent of I'm actually the parent of 2 special needs children, if we count the autism spectrum. He's high functioning autism, Asperger's is what they call that, but he's still autistic. But the other child is physically and mentally disabled. And that would be my firstborn, Aiden. And so caregivers are most knowledgeable about patients' needs. Oh yeah. Aiden can express himself. Oh, there's a phone ringing, so I'm just going to let it ring. Okay, done with that. Aiden can express himself, but it's very hard to interpret unless you've been around him a while. And so me and my wife, Angela, know what Aiden is saying, know what he's thinking, know that when he's upset, when he's not upset, what he wants, those type of things. But if you haven't spent a lot of time with him, then you don't know that he's actually trying to communicate to you. Okay? Preparation is a great thing. Let's so when we get an x-ray at Children's Hospital, we bring Aiden in. Of course, they know me because I'm an x-ray professor. So it goes a little bit easier, but I love it when they come in, when it's like nursing or the medical team or somebody else, and they come in and they just game plan. They say, okay, this is what we want to do. Now, you tell us, what do you think, when we try to do this, how's Aiden going to respond? How's it going to go? What's going to happen? Like, for example, they wanted to do a swallowing study on him where they would mix barium with various food textures, right? And get him to, or they wanted to do an esophagram to test, because he did have a surgery on his stomach when he was like 3. And they wanted to test to make sure that the surgery was still holding. It was like a wrapping and a clamping of the bottom of his esophagus, and they wanted to make sure that the seal was still good and he could clamp his esophagus off really good still. And they wanted to do a barium swallow where they would give him barium to drink and he would swallow it on the fluoroscope. And they said, and I said, I didn't say it. They said, how do you think he's going to do? I said, he's going to spit out the barium and laugh at you. That's what he's going to do. And he's possibly going to aspirate. If you really want to just check for that surgery and the esophageal clamp, just sedate him and do a scope. You're going to be in and out. It's going to be easier for everybody. He's possibly going to choke on the barium if you give him the barium to swallow by mouth because it tastes awful. And they're like, oh, okay, well, we could do a scope. That's a little bit more invasive, but I'm like, yeah, but it's going to be less risk you doing a scope than making him swallow barium. So they ended up changing their whole game plan based on what I suggested. So yeah, that's just an example. So yeah, go ahead and game plan, and remember, the parents with special needs children, those are not regular parents. Those are parents that have been through the gauntlet, okay? And so they are ready for anything, and they got some good ideas sometimes, okay? And so they're going to be like not just assistants and you tell them how to do things, they're going to be suggesting things to you because they have experience taking x-rays on their child. You see how that works? So they might actually have more experience x-raying. When you're a novice practitioner, the special needs parents have more experience x-raying children than you do. So wrap your head around that. Listen to them. They got some good ideas sometimes. All right. Radiation protection. We should always be shielding. Pediatric effects differ from adult effects. Okay. Pediatric effects can sometimes be more exacerbated, especially if they're late effects, because pediatric patients are growing, and so they have a higher cellular metabolic rate than adults, and that means their tissue is more radiosensitive on average. Okay, we should always be shielding. We should be using shortest exposure time possible. Okay, that's not only a dose reduction technique, but it's a motion reduction technique, and so it reduces the likelihood of a repeat due to motion. And so always short exposure times saves dose and saves us from getting a repeat, because it's very hard to move in 2/100ths of a second. Okay, there's just not enough time to move. Right? Communication. Okay, make sure the parents understand that, yeah, the radiation can have an effect, but the risk is very, very low. Okay, because as soon as you say radiation, some parents are like, oh no, it's, doom and gloom. That's dangerous stuff. Every bit of it is dangerous. That's not true. You have to have a certain dose before it becomes dangerous. Okay. Now cancer is the exception. Cancer can happen with even 1 photon. But cancer, there's so many things that the tracking back an x-ray that you got is very unlikely that the x-ray caused the cancer. Okay, it's more likely that it was contaminated drinking water or contaminated food or genetic variants, your predisposed genetic history, or your bad habits. as you become an adult. Those are much more probable to cause cancer than an individual radiograph when you were 2 or 3. Okay, but you do have to, if the parents say, is the radiation risky? You do have to say that it's a very slight risk. You do have to be honest with them, but the risk is really, really low. Okay, and with the modern equipment and the new computerized imaging, we use about 1/4 of the radiation that we used even back in the 80s with the films. Okay, and that's also true. Okay, explain why radiographers shouldn't be holding for exams. You will, as you become a credentialed radiographer, you will hold for the occasional exam, but the parents are better holders for the exam. And because the parent is only doing one X-ray series that day, you are doing 20 of them. And so if you hold, and that's the rule, you're going to be exposed 20 times. And so you're going to accumulate dose very, very rapidly. But if the parents hold, they're only doing one X-ray that day and then they're done. And then it's another set of parents. So we distribute the dose across the entire population of available helpers better if it's the parents that are holding, not the radiographers holding. Radiographers should be the last, because we're so frequently around the radiation, we really should be the last persons holding. Okay, even a patient care tech or a transporter assistant, they're a better person to hold than we are, because again, that's their only X-ray for the day. That's their only exposure for the day. Whereas we have to do 20 exposures if we are the ones holding. Okay, artifacts. Artifacts, because we have a larger dynamic range. Now, what's the dynamic range? The number of intensities that the new digital receptors can capture. You can think about it like the number of colors of gray that we can capture is well beyond what we could ever do with screen film. So our ability to capture intensities is better, and so more things show up. Like in film, you would never see cloth linen. But now if the cloth linen has a crease in it, we can see it. And that's because we got a wider dynamic range. Okay. Artifact size and body volume is greater in pediatric patients than adults. What does that mean? That means the patient, because the patient's lungs are smaller, your letter marker that is placed inappropriately is covering more tissue than on an equivalent adult-sized patient. Okay? And so your letter marker on a newborn or a neonate, your letter marker literally covers half of a lung, not just like 2 inches of the outer edge of the apice. No, half of the patient's lung is obscured by your improperly placed marker. Okay? So you got to watch that. And you got to watch that with all artifacts, not just your markers. Okay? Every artifact, every blanket, every sheet, every crease, every fold, every safety pin, safety pins are commonly in, every little snap on their gown, their little hospital gown, those are all artifacts, and now they're artifacts of significant size that can obscure whole parts of anatomy, like half of an organ is now behind this little button or this paper clip, okay, because body parts are smaller. And so watch the artifacts, remove all the artifacts before you image, okay? Make sure your marker's in the light field, but it's not superimposing the patient's shadow, okay? So your common projections, just real quick, you're going to do a lot of admin studies on on pediatric population, chest x-rays, pelvises, and hips. You'll do a skeletal survey or a scoliosis series for your teenage patients. Skull and paranasal sinuses, soft tissue necks, and then foreign body exams. That's kind of like a combination chest and abdomen. Okay, so basically all over the human body, we're going to take pictures. Okay. Some pathologies or syndromes that we'll have to deal with that can be diagnosed with x-ray. Cystic fibrosis shows up on a chest x-ray. Dysplasia of the hip shows up on x-ray, is diagnosed with x-ray. Most of the time diagnosed with CT now, but sometimes diagnosed with x-ray. Non-accidental trauma, that's child abuse. That's documented with x-ray. Osteogenesis imperfecta, that's brittle bone disease. That's diagnosed with x-ray. Fractures, benign and malignant neoplasms, pneumonia, progeria, and scoliosis, all diagnosed with x-ray. Okay. All right, your Pigostat, they removed this from it was in the older version. I guess the Pigostat is falling out of favor as of late, but the Pigostat will save your butt when you're x-raying alone on the third shift. The Pigostat is a nice immobilization device for an upright chest or an upright abdomen projection. Can even be adapted to a thoracic and lumbar spine if you need to, but typically it's the chest x-ray that we're doing or the upright abdomen we're doing. And so you place the child in the Pigostat immobilizer. There's a bicycle seat, their legs dangle, and their torso is anchored in between two plexiglass crescent moon shapes, and then you clamp them in place with their arms elevated above their head. This is going to freak them out, and they're going to start screaming. Okay? Just reassure mom or dad or whoever's assisting that we actually want them to scream, because it means they're going to fill their lungs up with air, and then we're going to get a good inspiration for the chest x-ray. And literally that is the strategy for timing the exposure. And so you just listen to them scream. You've got the button halfway depressed, and then all of a sudden they take in a deep breath because they need to scream again. And right at the top of taking the deep breath, that's when you hit the exposure and you capture it. Okay? And you get a good inspiration chest x-ray. Okay, the Pigostat actually for the 6-month to the 18-month crowd, it actually, if it's used consistently, it actually reduces the number of repeat exposures across that population for those patients that come to the hospital and get chest x-rays. It actually reduces the number of chest x-rays the department takes over time if everyone consistently uses the Pigostat. So it is a radiation protection device. All right, that's all I have for you for pediatrics. I was going to combo these, the geriatric lecture and the pediatric lecture, but they're both individually too long. So just pediatric lecture here. I'm going to try to get to the geriatric lecture before the end of the weekend and upload both of those to Schoology, but I'll definitely upload this one right now. Y'all take care. Have a good weekend. I'll see you.